next speaker. So my colleague, Mark, who is the Chief Solutions and Services Officer at Stratasys, he's an experienced board executive with extensive experience in large-scale public sector transformation. He's also a non-executive director at Alder Hey, where he also chairs the innovation endeavor there. And as well as all that, he's the partner in crime at Stratasys, trying to solve healthcare. So over to you, Mark.
Thank you very much, Naeem. Yeah, no pressure there then, right? Great to follow on from everything that Kim and Andy and Kate said. I mean, they're the ones genuinely at the sharp end of this and delivering real change, and their stories are really inspirational. What I'm trying to do and what we're trying to do at Stratasys is to support that endeavor. And Andy said in particular, data should drive all of the improvement we do, and we completely agree. So, just really want to make sure that the teams who are doing such great work have the data that they need to make good decisions. So if you could move on to that first slide, please, Carl. We are all about decision intelligence, as Naeem said at the very start, and that is about trying to make better decisions. It really is that simple. What data do you need and how should you use it to make better decisions? And there was a really interesting case recently, when the press were swirling around about which maternity services are going to be in this review that Secretary of State has initiated and Baroness Amos is now conducting. There was talk of the 10. Which are the 10? And I think if everybody at the centre was genuinely honest, if they were to be asked the question, which trusts right now are the top 10 highest risk maternity units in the UK? I don't think they would know. They don't have the data to say that. And it's really interesting that the horrific stories you hear, the cases of mortalities are thankfully very rare. They are tragic when they happen, but they are thankfully very rare. And being able to say that one trust or another is particularly bad or particularly good, particularly given the context that they all work within, is extremely difficult. So saying where is the highest trust, the highest risk in maternity right now is a very difficult and complex topic. And, we are frankly trying to wade in and help there because something needs to be done to try and clarify a very difficult picture into something that is actionable. If we take that second question around also how are trusts performing relative to their population health, we have seen in other areas that population health matters enormously. There are metrics like standardized hospital mortality index, which is the SHIMI, you may be aware of from wider healthcare. It is extremely skewed by population health, not just individual health, which is factored in somewhat to the metric, but by population health overall. One of the things we really recognize at Stratasys is that population health matters. So how does maternal health matter in terms of delivering outcomes? And then finally, there are some questions that seem on the surface to be quite silly questions. Do healthier mothers have fewer interventions and better outcomes? You would think, well, of course they do. But do they? And Naeem mentioned this at the beginning. There are questions here that we really need to get into, and we can start to see some of the evidence, but we can't quite see enough yet. So if you could move on to the next slide, please, Carl. So there is national maternity data available, and it's available monthly. It runs about 2 months in arrears, about 50 days after the end of the month. You get to see what has happened in the maternity trusts across England. That data has been around for about 10 years. And you think, okay, it's been around for 10 years. It should be pretty well formed. It should be pretty consistent data. Some of it is, let's be generous, okay. A lot of it is not at all. You can see here some of the statistics around how many data quality issues there are per trust per month, with the worst having sort of over 40 issues in their data sets per month from what we see, the best still having around 12 issues per month. A huge amount of what collectively I think all of those interested in maternity would really love to know is not captured. So, for example, patient choice is really important in maternity, but nothing in the data tells you whether the patient actually was listened to, whether they got their choice of form of birth, what interventions they were consulted on, not consulted on. Net promoter scores or some variant of that. We get the annual survey from the CQC quite a while, in arrears, as Andy has mentioned. Again, that's not available on a sort of monthly basis. We don't know on a timely fashion to really drive quick improvements. Are trusts giving mothers the services that they really want and need? And finally, there is no segmentation in the data. So we know that there are interventions applied. We know that within each trust, there are higher risk and lower risk mothers. We don't know whether the interventions are applied to the higher risk or the lower risk. We have to work at a trust level, and working at a trust level is sort of like, trying to do surgery with oven gloves on, or it's like looking at the data through meter thick frosted glass. You can kind of see what's happening, but it's quite imprecise. So there are real challenges around this. And I think it's worth just noting that in medicine overall and in healthcare, we have this challenge where the scientific progress is phenomenal, right? And an example I often use is we can now identify over 300 different types just of blood cancer. This is at the molecular level, but over 300 types of blood cancer. What we can't say is what's the right intervention rate in pregnancy for mothers of different levels of risk. We don't know. There is an interesting experiment going on across the country with trusts doing different things. That data needs to be captured, needs to be analysed so that we can really understand what are the right things to do and how to surface improvements. But given all of that, we do have some data. So if you move on, please, Carl, on to the next slide. Thank you. So we have some data, and what we're determined to do is try and make the best of that, to say, how can this data be better presented, better interpreted to try and drive real improvement in maternity services? And what we've created is this thing called the Stratis Maternity Index. It is far from perfect, but it is absolutely an attempt and a start to say, let's try and make sense of this. Let's try and actually help each trust on a month-by-month basis understand where they are relative to others, how they're performing, even down to an individual metric level, what is going on within their service, and what does that imply? So there's over 140,000 lines of code and configuration. A lot of that, frankly, is trying to clean up the data. And then we have used AI, but we've been able to say, well, we've got more than 5,000 different trust months, as we're calling them now. So this is monthly submissions by each trust, 5,000 trust months of data that we can train the AI on. There is plenty of guidance out there. There is plenty of research on what good maternity practices look like. How can we put all of this together to say, let's make sense of this data and try and inform real improvements? And the way that we try and do that is to pull these into themes, pull the data into themes that everyone can understand, and then pull those themes together into overall scores, again, to try and answer questions like, okay, well, where is most risk right now? This is available for trusts, for ICBs, for groups, for regions, nationally, for organisations to access. So this is an interactive online service. And I know you're kind of thinking, all right, just stop talking, Mark, and show me the thing. I will get into that and show you. I will also just say, I wondered about whether to show a named trust, whether to kind of obscure the names and blank them out. What I've opted for is actually to show you an actual trust. I appreciate many people watching this right now will be quite nervous. I have picked a good trust, as I'm sure you would expect, to show you what the data can look like, and also to be able to tell you the story, because I think it's more powerful that way. So if you move on, please, Carl. So this shows you, first of all, just sort of some screenshots of the service, but starting off with the overall risk view. And from left to right, you have every maternity trust in England scored as at September, which is the most recently available data, going from the best performers on the left to the worst performers on the right. And from this, we have picked out Northern Lincolnshire and Goole. Northern Lincolnshire and Goole are probably not a trust that you've heard of very often, certainly not in the context of very high-performing maternity services. But take it from me, they are very good, and I'll explain why. You may be looking at this and going, okay, well, they look like they're sort of middle of the way through the green side, so at least they're on the right side, but they're not right at the top. And I'll explain, first of all, what this risk view shows. So this risk view is about genuine risk, and it's taking into account essentially everything. Many of the things it takes into account are far outside the trust's ability to control. So, for example, how healthy are the mothers at the point of booking? That is somewhat within the control of the trust, but the vast majority of it is outside of their control. So it's looking at risk within the population. It's also looking at things like volume. So those with higher numbers of births will tend to skew to either end of this spectrum, because if you have, for example, some high-risk practices at a hospital with very many births, that obviously presents a large overall risk, lots of opportunity for things to go wrong. If you have a relatively small trust, then that tends to dampen down the risk or dampen down the benefit accordingly. So what we then do is we say, okay, how do we try and factor out some of the things the trust can't control and get a view of how that trust is performing? So if you go on to the next one, please, Carl, you can see that on a performance view, Northern Lincolnshire and Goole jump up to second. And they are doing extremely well because there is a significant difference between the average health of the mothers that they serve and the outcomes that both the mothers and the infants receive from the maternity services. We basically measure that by looking at these theme scores, collecting lots of data together and saying, okay, well, let's assess the overall maternal health. Then let's assess the maternal outcomes. Let's assess the neonatal outcomes. And let's look at the difference between those. Essentially, if you took average performance in England and predicted based on given maternal health where the neonatal outcomes should be and where the maternal outcomes should be, do the trusts beat or miss that target? And you can see that Northern Lincolnshire and Goole, in this instance, substantially beat that target. So this is sort of the performance view of the world. There's also a data quality view. I won't show you that due to the time, but essentially you can imagine that just shows the quality of the data and how trusts rank accordingly. If you can move on, please, Carl. The kind of really important thing we're trying to get at here is that we can do these sort of indexes, and that may be somewhat interesting. Lots of people in the NHS, particularly in the trusts, love a league table as long as they're at the right end of it. They like to discuss kind of where they are in the league table, but the league tables only matter if they actually drive action and improvement. So what we're trying to do is really make this a useful model and get into, okay, so what? So Carl, if you move on, please, to the next slide. So I'll give you a moment just sort of to read this whilst I'm talking. But what we do then for every trust is we break out the narrative. So looking back over the last 2 years, what's happened? And that's demonstrated both in terms of the lines on the graph, can you see things going up and getting better or going down and getting worse? Various different scores so you can start to understand exactly what's going on. But importantly, every month, a really clear narrative that pulls out the most important factors and shows against various themes and various metrics, how is the trust doing? This narrative is really important to help trusts understand where they are and their kind of so what of all of these numbers. And again, Carl, if you move on, please, you can see this also in some of the lines of the charts. So we're looking here at the performance score trend over the last 2 years for Northern Lincolnshire and Goole, and you can see a pretty steady upwards trajectory of really good performance, but with a sudden dip around September or October 2024. So, you can start to kind of form theories of, okay, well, what might have happened here? How do we delve into what's going on in this data? On the right-hand side, you can also see the suggested actions. So these essentially list the areas where improvement is suggested based on the data available. And even though Northern Lincolnshire and Goole, in this instance, is really well performing, there's always things you can do better, right? They're not at the top for every single metric. So the AI pulls out exactly relative to other trusts, what could be done better, and highlights some of those. Now, if we look into that dip, and if you move on, please, Carl, we look at kind of some of the more detailed themes. You can see that most of the dip actually was in neonatal outcomes. So something happened in September, October 2024 that caused a real dip in at least a recording of the neonatal outcomes. And you can then start to look into, okay, well, what was this? The tool shows you all the various outlier metrics, as you can see on the right-hand side. It also shows you the key changes over 12 months. All of those kind of listed outliers are links. You can click on those and go into exactly what the data shows for that specific item. If you move on, please, Carl, you can see this is then the breakdown for selected data within neonatal outcomes. And you can see that point around September, October, something very strange happened. It's kind of like firework went off and some of the metrics went in very different directions around neonatal outcomes. You can see there some of the, for example, APGAR scores suddenly went up, but some of the other metrics around, the gestational length, for example, the weight of the babies suddenly to go in very strange directions. And the tool here did partly its job, which is to, as soon as the metrics start to become not believable, it starts taking them out of the equation. The trust also at this period stopped reporting a couple of metrics, but the tool took out those that were going completely off in unbelievable ways. And you can see the gap until it starts to recover again. And if you go on, please, Carl, there is nothing particularly scary or malicious here. This was actually a BadgerNet go live. So this was a new system coming in for maternity data with some typical teething problems, and then normal services resumed, and you see that progress continue upwards, right? But imagine it's not a BadgerNet go live. Imagine it's something genuinely happening, going wrong within the system. You see various metrics going off. At least you can understand and explain why and dig into what's happening. If you move on, please, Carl. What you can do in the tool then is look at, down to very individual metrics, 84 different metrics you can look at. You can see the raw values of that metric. You can see the relative score. So this is the score compared to every other England acute trust. You can see that the mean across all of the trusts is that grey line there, and then the performance is shown here on the relative. You could also flip this over to show the national rank. So you can see that for spontaneous delivery, Northern Lincolnshire and Goole do very well. They're well above average, around 2 standard deviations above average. So they are having good outcomes with a high number of natural births. You can dig into this for each of the data items. If you move on, please, Carl. We're then learning some really interesting things. You can take all of this data, and not just at the trust level, you can put it all together and say, okay, well, what does this tell us? Well, let's take one that's not very surprising. So neonatal outcomes tend to track maternal health. If you have healthier mothers, you have healthier babies. The relationship shown here, highly statistically significant. I think in reality, the relationship is going to be far stronger because it's going to be averaged out at every trust. So although at a trust level, per trust month, we are seeing healthier, I think trust with healthy mothers basically have healthier babies, and there is strong correlation there, even when you take out other factors. You go, if you were looking at an individual case level basis, this relationship would be even stronger. However, if you move on, Carl, what's really interesting is that maternal health doesn't seem to improve maternal outcomes. Again, this is sort of like looking at the data through meter-thick frosted glass because it's at a trust level, it's not at the individual level. But there's something going on that says, why do healthy mothers not have far better outcomes? And if you move on to the final piece, Carl, one of the things that we start to see is actually healthy mothers get, if anything, slightly more interventions than unhealthy mothers. You split them into quintiles in terms of the trust with the healthiest mothers and the trust with the least healthy mothers. You can see that those with least healthy mothers on the left-hand side have more inductions, so about 34% induction rate, but they have a high number of natural births. They have a lower number than the highest rank of emergency cesareans. So there's something not right in terms of the intervention rates within the country, in terms of the science and the metrics behind when to intervene and how to intervene. And these interventions are often causing the mothers who are healthy and, in areas that you would expect to have very good outcomes, the mothers themselves aren't having the outcomes we would expect. And what we really want to do is get into the next levels down of data to understand why and to help trusts improve their services. And that's it from me. But Carl, if you move on to the last slide, it just says, if anybody would like trial access to this, please email me from your organizational email address so that I know that you are part of one of these organizations and can verify that. Then happy to give you trial access to have a look at this system and certainly access to your data, not access to everyone's, but access to data that's relevant for your role. So I will finish there. Thank you.
Thank you, Mark. As we've seen, a great example of how data can be used to help leaders and frontline staff to start making decisions better and work with imperfect data as well. I couldn't resist making the connections between Kate's example, Andy's, and what you were discussing in terms of the ranking of different organizations. And one thing which I can't resist asking a question, how does the SMI rankings align to the CQC ratings?
So it's really interesting because it doesn't. The interesting thing about CQC is that they are not looking at outcomes. They're not looking at the outcomes data, not least because they don't have a good sense of the outcomes. The data isn't there. That's part of what SMI is trying to create. It's trying to create that outcomes data. So if you take Northern Lincolnshire and Goole, there's 3 hospitals. 2 of them are rated requires improvement for maternity and 1 is rated good. So I think that's probably quite typical. We've heard about the devastation to morale that some CQC ratings can have. There doesn't seem to be the science behind the CQC ratings, doesn't seem to be the rigor behind them that explains why they are what they are, or more importantly, what you do about it. And we've heard these great stories from Andy and from Kate of good leaders with great teams, or great leaders with great teams, I shouldn't play them down, can corral efforts to say, okay, let's work out what's wrong and let's improve. But you don't get that inherently from the CQC reviews. What we're trying to do with the maternity index is really give you that. Well, why? You can go to the lowest level to, the individual metrics. Why are you saying this? Why are you saying that we are ranked below these other trusts or above these other trusts? Exactly what is it that needs to be different to improve that ranking. And that's what we're trying to get to.
Brilliant. Thank you, Mark.